Good morning, everyone. My name is Luz Delay Ziegler, and I am an MBA student of National American University with emphasis in healthcare administration. I will be sharing to the group today about the Healthcare Initiatives Plan based on documented best practices with fiscal, regulatory, and policy issue considerations. I will be sharing three countries. The first country that I would like to share is the United States of America. The U.S. healthcare delivery system has major changes and reforms. In March 2010, President Obama of the United States enacted the Patient Protection and Affordable Care Act, commonly known as Obamacare or ACA, and it has five purposes. The first purpose is to realize near universal coverage. Second, increase affordability of coverage. Third, increase quality and efficiency while decreasing unnecessary costs. Fourth, to reinforce primary care. And fifth, invest in public health by increasing the use of preventive care and community resources. The U.S. delivery of care and healthcare coverage has primary care setting. Patients have free choice of medical provider from in-network providers and not required to register with a primary care practice, depending on their insurance plans. Patient-centered medical homes and accountable care organizations are tested and implemented, improving quality and care coordination. Medicare pay monthly fees to primary care providers coordinating care with multiple chronic conditions. Insured patients directly responsible for portion of physician payments, while uninsured patients are responsible for all or part of physician's charges. Charges can be waived or reduced with charity care. Physicians are paid through a combination of methods such as capitation from the private insurance, negotiated fees from the private insurance, and administratively set fees from the public insurance, which are Medicaid and Medicare. The U.S. delivery of care and healthcare coverage has an outpatient specialist care. Specialists work in both private practice and hospitals. PPO or Provider Preferred Organization plans allow patients broader indirect access, while HMO or Health Maintenance Organization plans require referral from a primary care provider to see a specialist, thus limit patients' choice of specialist. Medicaid beneficiaries and uninsured has difficulty accessing specialists because of low reimbursement rates. Specialists are paid through capitation, negotiated fees, and administratively set fees, typically not allowed to bill above the fee schedule for services offered in network. Specialists can see patients, both public and private insurance. The U.S. delivery of care and healthcare coverage also has an after-hours care. After-hour access to primary care is limited. Only 34% of primary care doctors reported having after-hours care arrangements, and care is often provided by emergency rooms. Urgent care centers in the U.S. provides weekend after-hours care. Most urgent care centers are independently owned by physicians. About 25% are owned by hospitals. Some insurance companies make after-hours telephone advice lines available. The U.S. delivery of care and healthcare coverage has a hospital care settings. Hospitals can be nonprofit. In the U.S., there is about 70% of beds nationally. For profit, about 15% of beds, or public, 15% of beds. Public hospitals also serve private patients. Hospitals pay through a combination of methods including per service or per diem charges, per case payments, and bundled payments, in which case the hospital may be financially accountable for readmissions and services rendered by other providers. Some hospital-based physicians are salaried hospital employees, but most are paid on some form of fee-for-service basis. Physician payment is not included in Medicare's diagnosis-related group or DRG payments. The U.S. delivery of care and healthcare coverage has also a mental health care settings, provided by a mix of for-profit and non-profit providers and professionals including psychiatrists, psychologists, social workers, and nurses with prescriptive privileges. Most insurance plans cover inpatient hospitalization, outpatient treatment, emergency care, and prescription drugs. Other benefits may include case management and peer support services. Insurance coverage of mental health care has been less extensive than care for physical health conditions, with different prior authorization requirements, higher cost-sharing structures, and limits on inpatient and outpatient visits. ACA, or Affordable Care Act, aims to improve mental health parity by establishing mental health care as an essential health benefit, applying federal parity rules to ensure coverage incomparable and increasing access to health. Integrated mental and primary health care is limited, as many insurance plans carve out mental health services to capitated managed care behavioral health. The U.S. delivery of care and healthcare coverage is a long-term and social support settings, provided by a mix of for-profit and non-profit providers. Medicaid offers the most extensive coverage of long-term care, although it varies from state to state within federal eligibility and coverage requirements. Since Medicaid is a means-tested program, patients must often spend down their assets to qualify for long-term care assistance. However, hospice care is included in a Medicare benefit, as are skilled short-term nursing services and nursing home stays for up to 100 days. Long-term care insurance that offers comprehensive care is available but rare. Most certified nursing facilities are for-profit, about 68% here in the United States, while 25% are nonprofit and 6% are government-owned. Caregiver support programs and personal health budgets, such as cash and counseling programs in Medicaid are available in some states to support caregivers and recipients of home-based care. The next screen is the U.S. Organization of Healthcare System. This presentation will tell us how public financing and private financing works here in the U.S. The next screen is about the U.S. healthcare patient participation. Patients involved in decision-making process by expressing opinions about different treatment options, including sharing information, feelings, and signs, and accepting health team instructions. The patient participation motivates service provider and healthcare team to promote participation of patients in treatment decision making. The benefits of patient participation in the healthcare setting are: patients' participation in decision making and healthcare and treatment improve treatment outcomes. Patient participation consider patients as equal partners in healthcare decision making process and are encouraged to actively participate in their own treatment process and follow their treatment plan. The benefits of patient participation, in addition, increase patient satisfaction and trust. It gives higher patients' quality of life. It reduces patients' anxiety and emotions. It better understands personal requirements. It gives positive and direct professional communication with positive and lasting effects on health. In addition, it gives patients empowerment and providing better patient health. And it receives different opinions of patients about a common subject, planning and decision-making improvements through combined opinions of patients, improvement of monitoring and evaluating services. In addition, patient participation gives a better decision making due to access to different views. It increases trust in services due to increased freedom. It gives knowledge and transparency. It gives a substantial opportunity for dealing with inequalities in health and access to services. It also encourages a sense of independent responsibility for patients and for workers. It gives career promotion for most staff due to positive feedbacks from patients, and it reduces possibility of patient dissatisfaction. The U.S. healthcare coverage expand Medicaid to include everyone with income below 133% of federally poverty level. It established state-based insurance marketplaces for individuals and small businesses. It provides insurance subsidies for low and middle income individuals and tax credits for small businesses. It institutes a series of insurance regulations, including guaranteed issue and community rating. It eliminates co-payments for recommended preventive services and immunizations. It established a mandate for most individuals to have health insurance or pay a fee. Excuse me. It created a patient-centered outcomes research institute to conduct comparative effectiveness results. It creates Center for Medicaid and Medicare Innovation to develop and test payment models for improving quality and lowering costs. Healthcare coverage established independent payment advisory board with a mandate to reduce the growth of Medicare expenditures through payment reforms. It creates a shared savings program in Medicare for accountable care organizations that take responsibility for efficiently providing care to a defined population and meeting quality targets. The U.S. healthcare coverage temporarily increased Medicare and Medicaid payments for primary care. It expanded federally funding for federally qualified healthcare centers providing care for low-income and uninsured individuals. The next country that I would like to share today is Canada. Canada delivery of care and healthcare coverage has primary care settings. Primary care where general practitioners and healthcare specialists act as largely as gatekeepers. In several provinces, networks of general practitioners work together and share resources. Patients have free choice of primary care doctors, although in some areas choices are restricted owing to limited supply. Provincial and territorial ministries of healthcare negotiate physicians' fee schedules. Canada delivery of care and healthcare coverage after hour care provides physician and mainly privately owned walk-in clinics and hospital emergency rooms. Most provinces and regions has a free telephone service. They call it telehealth. It is available 24 hours a day for health advice from a registered nurse. Primary care physicians were not required to provide after-hours care, although many of the government-enabled group practice arrangements have requirements or financial incentives for providing hours care to registered patients. 46% of physician practices in Canada had arrangements for patients to see a doctor or a nurse after hours, with the highest rate in Ontario at 67%. 30% of physicians receive notification of hospital emergency department visits by their patients, and about a quarter receive a full report on specialist consultations. Canada delivery of care and healthcare coverage in the hospital care setting. It is a mix of public and private, predominantly not-for-profit organizations, often managed locally by regional authorities or hospital boards representing the community. In provinces with regional health authorities, many hospitals are publicly owned, whereas in other provinces, such as Ontario, they are predominantly private and non-profit corporations. In Ontario, government provides funding to 145 not-for-profit hospital corporations and 6 private for-profit hospitals. Generally, it operates under annual global budgets negotiated with the provincial or territorial Ministry of Health or regional health authority. Hospital-based physicians are not hospital employees and are paid directly by the government on a fee-for-service basis. Patient participation in Canada. Patients do not participate in the reimbursement process. Reimbursement exclusively takes place between the public insurer in Canada is the government and the healthcare provider. Monetary exchange is practically non-existent between patient and healthcare provider. Health disparities are a significant issue in health policy, as some demographic groups suffer from higher burden of illness than others. There is no single body responsible for addressing health disparities, but several provincial or territorial governments have departments and agencies devoted to addressing population health and health inequities. In addition, healthcare coverage in Canada. The Ministry of Health in each province is responsible for controlling medical costs. The operating budgets of hospitals are approved and funded entirely by the ministry in each province, and an annual global budget is negotiated between the ministry and each individual hospital. Capital expenditures are approved by the ministry, which funds the bulk of spending. Physician fees are determined by periodic negotiations between the ministry and the provincial medical associations. Canada delivery of care in the mental health setting. Universal coverage for physician provided mental health care alongside a fragmented system of allied services. Hospital mental health care are provided in specialty psychiatric hospitals and in general hospitals with adult mental health beds. Hospital and mental health care provided in specialty psychiatric hospitals and in general hospitals with adult mental health beds. Community mental health services include case management, community-based crisis response, and supported housing. Psychologists may work privately and are paid out of pocket or through private insurance or under salary in publicly funded organizations. Mental health has not been formally integrated into primary care. The delivery of care in Canada also has a long-term care and support. Long-term care and end-of-life care provided in non-hospital facilities and in the community and are not considered insured services under the Canada Health Act. Spending on non-hospital institutions, of which the majority are long-term care facilities, are accounted for just over 10% of the total health expenditures. A mix of private for-profit, private not-for-profit, and public facilities provide long-term care with variation in ownership across the country. Public funding of home care comes either through provincial or territorial government contracts with an agency to deliver services. Provinces and territories are responsible for addressing palliative and end-of-life care in hospitals. The next screen is the Canada Organization of Healthcare System. This presentation will give us an idea how healthcare system operates in Canada. Canada healthcare system has patient participation, but from the point of view from patients, it says patients do not feel they are involved in decisions related to their care. They do not feel they have the opportunity to ask for what they want and need during appointments. Providers do not take time needed for each patient and do not give them the opportunity to ask questions. In addition, providers do not check in with patients to see whether they are explaining things in a way patients can understand. Patients do not feel they have the opportunity to ask their provider to explain things again if they do not understand. The last country I would like to share to the group today is the New Zealand. New Zealand delivery of care has primary care settings. General practitioners act as gatekeepers to specialist care and are usually independent, self-employed providers compensated by a capitated government-determined subsidy. This is similar to Canada. General practitioners work together with practice nurses with an average of 3.48 general practitioners per practice. Nurses are salaried and paid by general practitioners. Patient registration is not mandatory, but general practitioners and PHOs have a formally registered patient list to be eligible for government subsidies. PHUs receive additional per capita funding for promoting health, coordinating care, reducing barriers to care for the people who can least afford primary health care, and providing additional services for people with chronic conditions. Most general practitioners belong to an organized network that provides management and other clinical support services. The New Zealand delivery of care has an outpatient setting specialist care as well. It is a dual practice in specialist care and are employed by the district health boards. Many specialists will be based in multi-specialty clinics but work independently, renting their office from the clinic. Private specialists are mostly in larger urban centers, set their own fees. Insurance companies have little, if any, control over those fees, although insurers will pay only up to a maximum amount, meaning that patients pay any difference. In public hospitals, patients are generally have limited choice of specialists. New Zealand delivery of care also has an after-hour care. The general practitioners are required to provide after-hours care. General practitioners work on call in rural areas. A nurse practitioner with prescribing rights may provide first contact care. General practitioners provide after-hours service on a roster at purpose-built, privately owned clinics in which they are shareholders. Some patients visit the hospital emergency department instead or avoid after-hours service altogether. A patient's usual general practitioner routinely receives information on after-hours encounters. The public also has access to the 24 hours, 7 days a week, phone-based healthline, staffed by nurses who provide advice for general health questions. Plunkett Line provides a similar service for child and parenting problems. New Zealand delivery of care also has a hospital care settings. Public hospitals provide all emergency and intensive care, receive a budget from owners, the district health boards based on historic utilization patterns, population needs or projections, and government goals in areas such as elective surgery. Budget includes the cost of health professionals and other staff who are all salaried. Private hospital patients with complications are often admitted to public hospitals, in which case the costs are absorbed by the public sector. Specialists who receive salaries in public hospitals can maintain their own private clinics or treat patients in private hospitals where income is on fee-for-service basis. Public hospital services are provided largely by consultant specialists, specialist registrars, and house surgeons. New Zealand delivery of care in the mental health care settings. Access mental health care through primary mental health services in the community, often through their general practitioners, who will then coordinate any referred services, but also through school-based health services and community services provided by non-governmental agencies, which are all publicly funded. DHBs deliver a range of mental health services, including secondary services such as forensic services, acute inpatient services, community-based services, and support to primary care providers. DHBs also fund non-governmental organizations to provide a range of community-based mental health services. Ashbourne Clinic is a private psychiatric hospital funded primarily through its contract with the Ministry of Health and by private clients. The New Zealand Long-Term Care and Social Support. It funds long-term care on the basis of needs assessments, age requirements, and a means of test. They fund these services for those over 65 years and those close in age and interest. Eligible individuals receive comprehensive services of medical care. Older or disabled people receive in-home care, and younger disabled opt for individual budgets to arrange their own in-home care providers. Respite care is available to relieve informal or family care, and in some circumstances there is ongoing financial support. Residential facilities, mostly private, providing long-term care. There is a network of hospices provides end-life care with approximately 70% of its funding coming from DHBs and the remainder through fundraising. Palliative care is provided in the community as well. The next screen is the organization of healthcare system in New Zealand. This presentation will give us an idea how healthcare system in New Zealand works. New Zealand, as far as the research goes, the student researcher did not find anything that says patient participation, but the student researcher found consumers' rights and duties of providers in the healthcare settings. There are 10 rights that a consumers that are available to consumers. Number 1 is right to be treated with respect. Right to freedom from discrimination, coercion, harassment, and exploitation. Right to dignity and independence. Right to services of an appropriate standard. Right to effective communication and be fully informed. Right to make an informed choice and give informed consent. Right to support. Right in respect of teaching or research, and right to complain. Compare and contrast. The differences between Canada, New Zealand, and the US is the role of private healthcare insurance and spending levels. Canadians and New Zealand have universal access to publicly funded healthcare services, primarily physician and hospital services. In contrast, the majority of US citizens require private insurance to cover the cost of medical care services. Public insurance is provided for the poor, which is Medicaid, and for those over age 65, it's called Medicare. Those who had an unmet health care need asked the reasons for barriers to not obtaining needed health care. The results indicate that among those experiencing unmet healthcare needs, waiting excessively long care was the primary care reason. 32% in Canada, while cost was the primary reason, 53% among similar US patients, regardless of insurance status. The proportion reporting cost as a reason for unmet healthcare needs in the United States was 40% among the insured and 84% among the uninsured population. Compare and contrast. The end result of the U.S. approach to healthcare is poorer health based from 3 indicators of healthy lives: mortality amenable to medical care, infant mortality, and healthy life expectancy at age 60 in comparison to other advanced industrialized nations. The United States health care specialists are among the best in the world. However, treatment in the U.S. is inequitable, over-specialized, and neglects primary and preventative care. Health care spending in the U.S. far exceeds that of the only country without a publicly financed universal health care. It still spends more public dollars on health care than all but 2 countries. Compare and contrast. Americans have relatively few hospital admissions and physician visits, but are greater users of expensive technologies such as magnetic resonance imaging, commonly known as MRI machines. Available cross-national pricing data suggests that prices for healthcare are notably higher in the United States, potentially explaining a large part of the higher health spending. In contrast, the United States devotes a relatively small share of its economy to social services such as housing assistance, employment programs, disability benefits, and food security. The next screen is the result of healthcare spending in year 2013. The data was gathered by OECD Health Data last year, 2015. The result says that uh, Canada is very efficient as compared to the other two countries. It follows New Zealand, and the last is United States. The student rank healthcare system based from three criteria: delivery of care, patient participation, and healthcare coverage. The student rankings are the delivery of care. The student decide that USA has an efficient delivery of care, so she rated USA as first, second New Zealand, third Canada. According to the data gathered by the student researcher, when it comes to patient participation, USA comes first, second Canada, and third New Zealand. When it comes to healthcare coverage, the student researcher rated USA as first, second Canada, and third New Zealand. The reasons why the students rank on those orders are: though the United States of America does not have a full universal healthcare coverage system, patients are seen regardless of their ability to pay, and it is based according to the severity of care needed. Usually, it goes through a nurse triage line. The student researcher ranks USA first based on delivery of care and healthcare coverage. After some minor changes of the Affordable Care Act, that some who are previously uninsured now have a partial coverage depending on the income level. There is no non-incident report stating people dies because they do not have coverage. There is a second reason why the student researcher ranked on those orders is the student researcher ranks USA first in the patient participation criteria for reasons regardless of the patient's ability to pay. Every healthcare facilities and providers of care are providing patients the opportunity to be involved and participate in the treatment and overall healthcare planning. Patients are not just engaging of what providers told them to do. Patients are participants of the entire care process. Most Americans, mo- excuse me, most American people do not care about how much they owe. Excuse me. Most American people do not care much about how much they owe. The most important is the quality of care they received. The U.S. healthcare system could integrate to improve patient care. The student researcher has three recommendations for best practices. Number one, to maximize value of patient is to offer the best healthcare at the lowest possible cost. Second recommendation is primary care should be integrated to the entire U.S. healthcare system. And the last recommendation is a full universal coverage should be integrated for those who are uninsured. Thank you so much for listening, and if you have any questions, feel free to ask. You can email me at ldasigler@gmail.com. Thank you all and have a wonderful day. Bye.